Thank you, sir. Good evening, everyone. I am Anisha Mohan, Nursing Officer of cghs Pune. Today, I am here to present before you what as a team we did this vendor. The team consisted of Dr. Vinita Kaushik, Dr. Pinaki Sengupta, Dr. R. Patwardhan, Dr. Suhrid Vaidya, Dr. N. Thadge, Narendra Singh Bhati, and Anisha Mohan, myself, Nursing Officers of cghs of Pune. And what we did during this winter was a program on pulmonary rehabilitation for chronic lung disease patients in resource-constrained settings. As the saying goes, no one can whistle a symphony, it takes a whole orchestra to play it. The program gained its success through the efforts of the whole team. The major focus of the pulmonary rehabilitation was to break the vicious cycle of inactivity. An individual who is feeling breathless becomes afraid of strenuous activities, and once he is afraid of the activities, he tends to avoid those activities which makes him breathless. And as a result, he does less activity, which further leads to the weakening of his muscles. And compared to a normal person, the muscle of the weak person, the person's weak muscle, it uses more oxygen and it is less efficient in performing the exercises. So this will lead continues. So the major focus of the program was to break this vicious cycle. The equipments and manpower required for the program. The equipments required were pulse oximeter, sphygmomanometer, stopwatch, walking track, and hand weights or TheraBand. The ideal setting is a multidisciplinary team of health professionals. That is a physiotherapist, exercise physiologist, dietitian, occupational therapist, pharmacist, psychologist, social worker, specialty nurse and physician. As we have already said that this was a resource constrained setting, hence all the roles were performed by the specialist nurse and the physicians.
Dr. Kamesh Rao to join. I'll explain this slide because I find Dr. Kamesh Rao is not connected. But this is what the slide tells you about pulmonary rehabilitation. Is Dr. Kamesh Rao back? All right. So if you want to treat...
Hello, am I audible?
Yeah, please go.
Yeah. Good evening, everyone. And first of all, hearty congratulations to Dr. Thadge and the team for the brilliant initiative. Before explaining the visual, I just would like to briefly touch upon this quality. What is the quality adjusted life year? It's one of the very important parameters to measure the evaluation of the outcome of health intervention program, whether it is a pharmacological intervention or a non-pharmacological intervention. It is a single measure that is used to quantify the length and the quality of life in combination. In simple words, the QALY is used to measure how long a person lives and how well the person lives. So one QALY is equal to 1 year of life lived in perfect health, and it is equal to 1. So when we consider death as 0 QALY, the value of QALY ranges from 0 to 1. So the closer the QALY to 1, the best the health of an individual. Okay. So now coming back to this visual, so we have the pyramid which is developed by London Pulmonary Network in association with London School of Economics. At the very base of the pyramid, you will find the flu vaccination costs, which costs £1,000 to bring about 1 QALY to cover the risk population. So going up, the Stop Smoking Initiative along with the pharmacotherapy, that costs £2,000 per QALY. And the topic of the discussion, pulmonary rehabilitation, costs £2,000 to £8,000 to bring about 1 QALY. So higher up we have tiotropium and LABA and LAMA and the triple therapy with ICS and LAMA. And at the peak, we have this telehealth, which we all talk about, but which has a narrow reach and costing very high. In other words, to simply say, the bottom line is the simple, cost-effective interventions can bring about excellent clinical outcomes, as well as the reduced disease burden and reduced queuing in the OPDs. This visual is basically done in UK, so you'll find it in pounds. But when it comes to Indian scenario, it will be much more cost-effective. So that's all, Dr. Darge.
Thank you.
Good evening, everybody. Am I audible?
Yes, sir.
Yes.
Why exercise? That's the most important aspect of treatment, because exercise is medicine. And now we have enough data to support that exercise can be used as one therapy, and it can bring down much more effective reduction and increase in the quality of life. What happens in case of patients who are chronically disabled because of some respiratory ailment? That they fail to do exercise. And as they fail to do exercise, as you can see, that it leads to defect in alveolar ventilation and diffusion. It reduces their aerobic enzyme activity. It promotes sedentary lifestyle and the complications of sedentary lifestyle, as well as it increases the comorbidity. All these things that add to the inflammatory cell apoptosis and low number of aerobic fibers. Now, what happens? We all are aware that when we exercise, the muscles require energy and they utilize oxygen to burn glucose to produce ATP molecule, which provides energy to the muscle fiber for contraction. Now, when the oxygen becomes a rare commodity, the glucose burning pathway, instead of going through the aerobic methods, they shift to the anaerobic methods, and the byproduct of that anaerobic method is lactic acid. And this lactic acid hampers, not only it generates very less number of ATP, but it also hampers the muscle activity by producing acidity. And this particular point where the oxygen utilization goes from aerobic to anaerobic method is known as lactic acid threshold. And this lactic acid threshold, as you exercise, it goes down. And this accumulation of lactic acid makes you feel dyspneic. What is dyspnea? Dyspnea is basically the fact that you are aware of your breathing. And this is what happens to the respiratory, the patients who have respiratory ailments. So if you make them exercise, this anaerobic threshold goes down, and they can exercise much more without having to do a conscious effort of breathing. So in other way, it reduces their dyspnea, and that is the essence of pulmonary rehabilitation program. And we have we have some myth that for respiratory rehabilitation program, you need to do only the muscles which are effective in your breathing apparatus. But it is not so. You have to make work with the large group of muscle, and then only you can get the benefit of exercise, and which in turn will help you become more rehabilitated in pulmonary rehabilitation. So I think that helps to understand why exercise is the most important part, and exercise involving larger muscle group is most important in getting the maximum benefit of pulmonary rehabilitation. I think that's it.
Yes, sir. Thank you. So Dr. Sood is going to tell us about pulmonary rehabilitation. Dr. Sood.
Yes, sir. So today, good evening, everybody. My name is Dr. Surud Vaidya. Today, I'm going to talk about do's and don'ts in pulmonary rehabilitation, especially interstitial lung fibrosis. This topic covers the basic precautions which patients are supposed to take in day-to-day lives, which would decrease the exacerbations of the disease, require less admissions, or maybe even require less pharmacological interventions, and have a better functional capacity without unnecessary unnecessary provocations of the disease. Now, these do's and don'ts have been divided into multiple areas so that we can cover them according to everything. The basic idea of pulmonary rehabilitation started with the concept that with some exercises, with some exercises, the pulmonary capacity can be increased therapeutically to a certain level, which would increase the subjective feel good, as well as decrease in the symptoms. Sir, can you switch to the next slide?
Yeah.
All right. So today we concluded the session. So today we interacted with the patients also. The benefits of the pulmonary rehabilitation were mostly twofold. One was subjective. Subjectively, patients felt better. They required lesser oxygen support. And the second part was the tests we conducted, 6-minute walk tests. The data showed improvements in the period of 4 weeks. So because of that, they were able to walk faster. They were able to walk for a sustained length of period of time. And the rest of the benefits are enumerated on the slides, which typically I have enlisted last time, like 1 minute back. So here we can see the types of pulmonary rehabilitation, which are outpatient, inpatient, and home-based. This particular lecture covered. I'm sorry.
You go on, Sood. There's a background noise.
Okay. All right. So the outpatient pulmonary rehabilitation, most of the topics have been will be covered in the next summary. There are some home-based pulmonary rehabilitation techniques and exercises also. Some of them were taught during these sessions. And inpatient pulmonary rehabilitation would cover the part where the patient is admitted and he recuperates in the hospital.
Thanks. Dr. Narendra Singh Bhatti would speak on how we conducted the program. Narendra Singh ji, are you there?
I think there's a cut zala.
Okay. So I'll take the slides if he doesn't come up. Narendra Singh ji, are you there? So we conducted in the following way. We registered 8 patients per session. So we take only 8 patients because we want to give a supervised exercise. So we can't handle more than that in a ideal setting. And every week we ran 1 session. So such 4 sessions we targeted on the first batch of pulmonary rehabilitation. The first.
Sir, I joined.
Yeah, please take over, Narendra Singh ji.
Okay. Good evening, everybody. Myself, Narendra Singh Bhatti. The rehabilitation program, how we conducted. Registration of only 8 patients per page were done, and weekly session was conducted. 4 sessions administered per batch. Orientation lecture of program delivered in first session. Now examination. We recorded vitals, administered pop dyspnea and fatigue scale, followed by 6-minute pop test. And post-test also be done. Practice session. Exercise were demonstrated and whole team supervised by patient practice. Educational lecture. Doctors provide educational lectures on the topic such as diet, how to use inhalers, etc. Exercise prescription. On the basis of result of 6-minute walk test, each patient prescription exercise provided by the doctors. Finally, one session given for the patient for clarify their doubts. Data collection. We collect data at baseline and end of the program. These were tools: 6-minute walk test, Bob and MRC dyspnea scale, asthma control test, COPD control test, St. George questionnaire. These are our data.
So you can see the 6-minute walk test being done in the video. Fortunately, we have a long tract of in the lobby, which we use for 6-minute walk test.
Zoom all Pune people, staff and all saying they are presenting on COPD.
I think Dr. Kaushik's lecture is not audible. Sir, is Dr. Kaushik's lecture audible?
No, nothing is audible.
Nothing is audible at me. Dr. Dhadge, sir, I think her lecture is not audible. The slide.
Ma'am, you're audible now.
So this was actually what Dr. Kaushik delivered in the lecture on tips, diet tips and air travel. She sent her voice on the slides because she couldn't join in person.
After this, essentially, am I audible, sir?
Yes.
We took lectures on inhalation techniques. The take-home message for the patients was that there are different types of inhalers, why inhalers are better than oral medications. Then we told them how to use MDIs or dry powder inhalers and how to use nebulizers. That the proper technique of using those inhalers and nebulizers is crucial to their treatment. I think patients understood these points, and we told them That retraining is very important because they tend to forget how to use it, or they feel that they are using it properly, but then when we check it, we find that they are not using it properly. We told them how to clean their nebulizers, how to use spacers, and how essentially to ensure that they are getting their medication properly, so that the dose can be interpreted in terms of what dosage they are taking and is it working for them. I think they understood the gist of what we wanted to tell them, because there were many queries and they asked how to use it, when to use it, what to do when they're very breathless. And we had to settle all those queries, and I think it helped them understand how to use inhalers, nebulizers for benefiting them properly. And in essence, we told them that if they are not able to do it properly, it is not their mistake. They should not feel guilty. It is our fault. It is the system's fault if they are not using the inhalers properly. So do not shy away from asking nurses or doctors to teach them or retrain them regarding proper inhalation technique for use of nebulizers, because that is the essence of treatment and proper treatment for these patients. That is what we sort of conveyed in trying to use inhalers properly. The second important thing which we did was that we supervised the exercises personally, because there were 8 patients and we chose 8 patients so that we could supervise individually their exercises, whether they are doing it properly, whether they are doing it for the particular length of time which we think they should be doing it for proper effect. And the breathing technique was also supervised while they did those exercises. So essentially we taught them stretching exercises, aerobic exercises, strengthening exercises, and breathing exercises. So all of these exercises were supervised by our team of doctors and nurses, so that it was safe for them. Whenever we thought they were getting dyspneic, we used pulse oxes and oxygen therapy, and we ensured that nobody is getting any problems because of doing those exercises. So these supervised exercises were competence as well. This is what was the essence of a supervised pulmonary rehab program.
Thank you.
That's it, I suppose.
So, thank you, madam. So, the program does not end by simply teaching them exercises, and it does not end by taking lectures. We have to ensure that their morale is very high when they go back at home. They do their exercises as we taught them. So we formed a WhatsApp group of all those 8 patients. We named it as Pulmonary Rehabilitation Batch 1. This batch consisted predominantly of interstitial lung disease. Most of them were IPF, few were of hypersensitivity pneumonitis. 2 of the patients were on oxygen at home, and these were the patient group of the batch 1. So you can see I personally send messages to make them feel better doing exercises by sending these moral boosting messages, and they responded how much time they did the exercise, what exercise they have done, what different types of exercises with different duration all patients did at home. So we advise 3 to 5 days of exercise, each session lasting for 30 minutes minimum was our prescription for each of these patients. And we followed this group for 4 weeks on a WhatsApp, and these are the sample feedbacks on that group from the patient. So we just didn't taught them and took their lectures and send them home to call again, but we followed them and we kept their moral at a high level to continue exercise at home. So these are the few images that you will see that these patients are actually started doing. We encouraged these patients to send their videos how they are doing it, whether they are doing it correctly or not. And what you can see, this lady is actually a very bad case of interstitial lung disease with a saturation between 90-92. And she, being very old, we thought she may not be able to follow at home, but she sent these two nice videos. This young old gentleman is 75 plus, suffering from idiopathic pulmonary fibrosis. He's showing us how he is doing aerobic exercises of climbing staircase using his home environment. So these were the feedbacks that we received from our patients. So we do it on every Friday between 3 to 5 p.m. We have a pulmonary rehabilitation. Whole of our team, we just learn what they did in that rehab program, starting from our nursing staff to our senior most doctors, even the retired doctors who participated as a team and conducted over a period of 1 month. And today was the last day of the session, which we conducted between 3 to 5 p.m. So there were some positive side effects, I would say, of this pulmonary rehabilitation program. So this wife of one of the patient started doing exercise along with patients. She's actually not a patient of any chronic lung disease, but by watching their exercises, she was also doing some of the exercises she could do. She's 70 plus, but she was happy doing those exercises with her husband during the session. And this was our first batch, a happy batch, which ended today of 8 patients. You can see the glare, the happiness on their face of the positive effects, not only on their dyspnea and exercise capacity, but on all their well-being. So this is our what we did this winter. We set up a pulmonary rehabilitation team with available resources, with available manpower, getting together all the team for this program. I will share this video of this lady, and this she described how she felt pulmonary rehabilitation. Unfortunately, it is in the regional language, but uh, what she was telling us. So I'll just translate what this lady said. This is a very important physiological concept of our pulmonary rehabilitation. The lady told that I was not able to walk even for a few distance, but I'm able to complete 3 rounds and then I sit down, but I'm not dyspneic even after walking 3 rounds. What is important point she said is, it is not only the exercise, it's a synchronization of the exercise with breathing. And that is the essence of this pulmonary rehabilitation. Your breathing is synchronized with specific respiratory exercises, which gives them patient the relief in the dyspnea that they need most, which cannot be achieved by most medicines, nebulizations, inhalers. So pulmonary rehabilitation is what a wonder can do in somebody's life, is what she just told us. So this was one of the feedback that we wanted to share with you. So I would like to stop here our presentation. We have 7 minutes left. I would want questions, suggestions, comments. And if any of the city is already doing pulmonary rehabilitation for us, we would like to learn from them. We would like to take feedback from them, how to improve this program even further. Because we are not experts in this, We have just started, we have just delivered a baby, which we have to grow to its maximum potential and take it further to benefit a large number of patients. We received a lot of support from the administration, additional director's office, uh, all the nursing staff, the MTS staff, all helped in this building this pulmonary rehab team for last 2-3 months. So I open the forum for suggestion, comments, and if there are any cities who are doing this pulmonary rehabilitation, we will like to learn from them, or if they want to give any input.